Hello, everyone. My name is Danelle Bjornson. I'm a psychiatric mental health nurse practitioner and co-owner of Northwest ADHD Treatment Center here in Portland, Oregon. I started this clinic 6.5 years ago because I'm passionate about treating adult ADHD. And the reason I'm passionate is that I have seen how transformative it is when you get the diagnosis right and can start the appropriate treatment. Today I'm going to share with you some of my experiences evaluating adults who present with attentional complaints. But first, why are we even here talking about adult ADHD? Children with ADHD demonstrate symptoms that are often easily identifiable, and most mental health clinicians and pediatric clinicians have had training about how to diagnose and treat it. With adults, not so much. But no matter where you practice, be it general psychiatry, psychology, or primary care, you will encounter adults with undiagnosed ADHD, especially during periods of transition. For instance, when they're starting college, entering the workforce, having children, and it's vitally important that we as clinicians are knowledgeable about this population. Adult ADHD is prevalent worldwide. This is not an American phenomenon, no matter what you see on social media. We know it's highly comorbid with other mental health disorders, and for many causes severe impairment and disease burden. Unfortunately, though, adult ADHD is often misunderstood by the medical profession and trivialized by popular culture. So is it any wonder, really, that it's underdiagnosed and undermanaged? ADHD is a neurodevelopmental disorder that begins in childhood with persistence of symptoms into adulthood for about 60% of individuals. As I tell our new clinicians, think of it longitudinally, not cross-sectionally. And by that I mean, when evaluating new patients, you're looking for evidence of symptoms from early in life, not something that's just been occurring lately. The core symptoms of ADHD are age-inappropriate inattention, hyperactivity, and impulsivity that cause impairment. Now remember, symptoms alone don't make a diagnosis. So if a patient comes in and they say they have problems concentrating or, they leave things undone, they have to also demonstrate that these are causing significant impairment or distress in their lives. As I mentioned earlier, adult ADHD is prevalent worldwide. The overall prevalence of adult ADHD in the United States is about 4.4% versus 2.8% worldwide. So the discrepancies in these prevalence rates between the US and other countries may simply be due to methodological factors. Now, prevalence is higher for males at 5.4% versus females 3.2%. And the non-Hispanic white group, 5.4%, had a higher prevalence than all other race and ethnic groups. ADHD is highly heritable psychiatric disorder, with heritability rates estimated to be between 70 to 80%. I once heard Dr. Russell Barkley say something to the effect, if you want a child with ADHD to respond better to treatment, you must also treat the parent. And one takeaway I got from that statement is that it's important to be mindful that this disorder runs in families. So why don't we just give a test then for ADHD, like a genetic test? The answer is that there are many candidate genes associated with ADHD, and at this time no test exists. There are many environmental factors associated with development of ADHD. These include prematurity, maternal stress, extremely low birth weight, in utero substance exposures to tobacco, alcohol, illicit stimulants, environmental toxins, severe childhood deprivation and trauma, and brain injury. Does everyone with genetic risk for ADHD go on to develop the disorder? Well, the answer is no. There's a very plausible hypothesis that ADHD is expressed when there's a genetic susceptibility for ADHD combined with some of the environmental risk factors we just mentioned. The DSM-5 criteria for diagnosis of ADHD include a persistent pattern of inattention and/or hyperactivity, impulsivity that interferes with functioning or development. In adults, 5 or more symptoms must have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts their social, academic, or occupational activities. Of course, the symptoms shouldn't be simply due to oppositional or defiant behavior, hostility, or failure to understand tasks or instructions. I'd like to draw your attention to the following statement in the DSM. Several symptoms were present in 2 or more settings prior to age 12. So you can see it'd be pretty easy to see how a child who didn't meet full criteria could have had symptoms of ADHD in childhood, but then not be diagnosed until later in life when their symptoms are more prevalent and impairing. Very quickly, I want to mention just a few of the inattentive symptoms of ADHD, such as forgetfulness, getting distracted easily, procrastination, and poor listening. These are common in adults. While the hyperactive and impulsive symptoms that are common in adults are inner restlessness, fidgeting, impatience, and talking excessively. Adults just don't report textbook symptoms. In fact, I'm more concerned when a patient comes in and they do report textbook symptoms. I've had kiddos in my office do somersaults on the couch, take their clothes off, swipe things off my desk. Now, if I had an adult patient coming in and acting like that or running about in my office, it would raise my concern about mania, not ADHD. The DSM criteria were developed for children, so keep in mind that adult symptoms often present differently. That adult patient with hyperactivity may not express it outwardly and instead report feeling restless or discomfort for being still for too long. And more commonly, the first things patients report are the secondary issues that result from a lifetime of underachievement, failure, criticism, and negative self-talk. A lot of times what the patients report, they report anxiety, depression, or as they describe it, feeling overwhelmed and stressed out.
Living with adult ADHD is exhausting. My life has always been a struggle at school, at home, even driving, and even with my friends. Every time I started a new grade, a new sport, or made a friend, my ADHD problem would creep back up and ruin everything. Like, people would like me at first. I'm a chill person usually, but after a while, me forgetting stuff, me not remembering things, people get tired of that. Can I tell you how that made me feel on the inside? I felt so dumb, so guilty, like I was a failure, like I wouldn't amount to anything worth a darn. So you ask me, what's the burden of living with ADHD? In one word, it's draining. It drains me from the inside and the outside. And it's a tough burden to have to carry 24/7.
So imagine for a moment you're seeing a patient who you aren't necessarily assessing for ADHD. There are some very common characteristics of folks who have undiagnosed ADHD that should clue you in to screen for it. For instance, if a patient's child has ADHD, or if the patient has treatment-resistant psychiatric disorders, let's suppose you're treating them for depression, anxiety, bipolar disorder, and the typical treatments just aren't working. If you see a patient that is almost always late for your appointments or forgets them, or who has a lot of trouble adhering to the treatment you've prescribed because they forget to take their medication on a daily basis, for instance, they forget to go pick it up at the pharmacy, it's a good idea to screen for ADHD. Several providers at my clinic, we put our heads together to come up with a list of commonly reported functional impairments patients have reported to us over the years. The next few slides are some examples and ways they may be interpreted as DSM-5 symptoms. I want to be clear, this isn't an exhaustive way that you could look at the symptoms. These are just a couple of examples of some ways that we might characterize those behaviors. One really common thing that comes up with patients with ADHD is getting distracted by social media or the internet when they're at work and losing track of time. Now, of course, this could happen to any of us, but with folks with ADHD, it's a lot more common, it's a lot more prevalent, and they have a lot more challenges breaking away from it to get going with their day. For instance, one patient told me he spent hours each day taking Google Maps vacations and then realizing several hours had passed and he'd gotten nothing done at work. So how might we interpret this in DSM-5 terms? Well, this could be an example of avoidance behavior, trying to avoid the task that's more challenging, or just getting distracted easily and novelty seeking. Another common issue is that many patients have to regularly work excessively long hours to complete the same amount of work a peer can in a typical workday. Many factors could account for this, such as distraction, poor attention, forgetfulness, and avoidance. So interestingly, many adult patients, they come into the office and they report challenges they experience at work, but they don't necessarily spontaneously bring up the impairments they're experiencing at home. When prompted though, or if they're accompanied by a partner, they can usually identify some difficulties at home. For example, they may have parenting problems as a result of inconsistency in rules, rewards, and consequences. The challenge for them often boils down to difficulties with forgetfulness, follow through, and organization. Maybe they make a rule and then they forgot that they made the rule. Many patients report they have difficulty with money management. If you ask about who manages finances, often they'll say they have a partner who does it, or they've set up auto bill pay because they were so frequently late or forgetful paying bills in the past. One woman I know overdrew her bank account, not because she forgot to make her car payment, but because she forgot she set up auto bill pay, and then she made the payment manually. We know that ADHD in adults can cause significant relationship issues. As we saw in a previous slide, conflicts with coworkers and partners are common due to many ADHD-related impairments. So often, the neurotypical partner will feel obligated to take on a parentified role to manage the deficiencies of the ADHD partner. And that causes tension and leads to resentment from both directions. So sadly, there are really significant secondary problems of ADHD in adulthood. Briefly, it can lead to higher rates of divorce, substance abuse, motor vehicle accidents, and increased rates of other psychiatric illnesses. Adults with ADHD tend to take the lower paying jobs, and they experience higher rates of unemployment and job loss. Last year, Dr. Barkley published an article that childhood hyperactivity was associated with a reduction in healthful years, but really shockingly and sadly, an 8.4-year reduction in total life expectancy. Some of the factors associated with this finding include poor lifestyle habits, increased risk for accidents and injuries, and higher rates of crime and aggression. Comorbidity is more of the rule versus the exception in ADHD. It's estimated that between 50% to 80% of adults with ADHD have at least one comorbidity. And of these, anxiety disorders tend to be the most common. You could probably agree with that. Well, this certainly makes diagnosis and treatment more complicated due to the overlap of the symptoms. And I think Dr. Jane will address this in the second half of the presentation. I want to take a moment to consider ADHD in women. In childhood, girls tend to have more internalizing symptoms such as daydreaming, whereas little boys are often disruptive in school, being the class clown. That prompts them to get evaluated. As they age, women may be misdiagnosed with mood or anxiety disorders. This can delay diagnosis and results in women often being diagnosed at a later age. In my experience, symptoms may worsen at transitional points of life such as college, starting new careers, or marriage and motherhood as responsibilities increase. Then later in perimenopause and menopause when estrogen levels decrease, which impacts dopamine levels. At my clinic, we propose the following minimum components of a thorough ADHD evaluation: screening, comprehensive biopsychosocial interview, and collateral report. A common screening tool is the ASRS version 1.1, a self-report screener. It's composed of two parts. Part A consists of 6 questions assessing the core symptoms of ADHD. Patients rate the frequency of symptom occurrence as either never, rarely, sometimes, often, or very often. If they mark 4 items in the shaded section, it's a positive screen. Part B is 12 items that provide further details about areas of impairment. Another screener is the ADHD RS4 with adult prompts. It is an 18-item scale with 9 items assessing inattentive symptoms and 9 for hyperactivity and impulsivity. The Winder-Utah Rating Scale is a retrospective questionnaire of childhood symptoms frequently used in research. I've used the words with adult patients' parents to help them recall symptoms from their child's early years. Over the years, I have had many patients referred to me who were diagnosed with ADHD after filling out a screener. I can't emphasize this enough. Screeners do not diagnose ADHD. However, they can signal a need that further evaluation should happen. The next component of an ADHD evaluation is a comprehensive diagnostic interview. This is the gold standard for diagnosing ADHD. This includes an HPI, a psychiatric history, substance abuse history, and these should focus on uncovering ADHD symptoms, but also ruling out other mental health conditions that could masquerade as ADHD or be a comorbidity. The most important thing that you may gather from this entire presentation, so please note this, avoid leading questions. Start with open-end questions, broad questions. For instance, instead of asking, "Are you having difficulty paying attention at work?" say, "Tell me about how you're doing at work." Then based on the response, drill down more deeply. So say you're having difficulty concentrating at work. Tell me more about that. When is this happening? What else is going on around you? How often? For the psychiatric history, you want to know what they've been diagnosed with in the past and also how they responded to medication. Substance use history is also key because we know so many of our patients have at least experimented with substances. Some patients come in and they're a little bit anxious about telling us about their substance use history because they think that we will deny treatment to them or judge them. And I try to normalize this part of the interview for patients by stating, a lot of my patients have tried drugs. What have you tried and how did it affect you? When assessing developmental history, I ask patients to tell me stories they heard about themselves as children. And when evaluating the academic performance, ask about each grade level beginning in preschool. A good diagnostic question is, if I were a student in your class, what would I have noticed? Or what would your teacher have said about you? Ask about each job your patient has held, including type of work, length of employment, disciplinary actions, and how they terminated. Were they fired or did they get bored and leave suddenly without a plan? How many total jobs did they have? One middle-aged man I evaluated had held over 50 jobs that he was either fired from or had left abruptly due to boredom or conflict with a coworker. Additionally, it's important to understand how patients function in their job. Some self-select jobs they will excel in despite having untreated ADHD. For instance, they may be fantastic car salesmen, but when promoted to management, fail miserably. We want to take a thorough medical history, or if you're a behavioral health provider, review medical records to rule out other conditions that can impact cognitive functioning. And finally, we need to know family history. It's not enough to ask about diagnoses because often patients just don't know, and they're often not even discussed in families. So ask about observable symptoms. Did anyone in your immediate family have the sorts of struggles you've told me you've experienced? The final component of a thorough diagnosis is collateral report. Patients may not realize the impact their symptoms are having or overemphasize the frequency they occur. And if patients are malingering, it would help to sort that out as well. It's so important to get the perspective of someone who knows the patient very well about their functioning. So usually parents are the best source of collateral if you can get it. Sometimes patients are reluctant to allow collateral report. Explore that with them. Sometimes it's because of a family history of trauma and they can't talk to their family of origin. Sometimes it's due to embarrassment. They don't want their families to know they're seeking help for ADHD. If you're not able to get collateral from a relative, other sources include medical records, therapy notes, employee evaluations, report cards, and driving records. So we've established this is a prevalent, highly impairing disorder. So then why is it missed? One reason is cognitive bias. The medical community may have bias that ADHD is overdiagnosed or overtreated, that adults just don't have ADHD. And if you've ever had to fill out a prior authorization form for a stimulant for a patient over age 18, well, you know then that the insurance companies seem to think so. Sometimes the medical community believes that patients are drug seeking, trying to get medication for performance enhancement or to abuse medications. Another issue is the overlap of psychiatric symptoms that can obscure an ADHD diagnosis. There was a survey of 1,900 physicians, 1,200 primary care, and 700 psychiatrists. Only 8% of primary care providers and 28% of psychiatrists felt extremely confident diagnosing adult ADHD. And lastly, if a patient has high IQ and/or a good compensatory system, like a personal assistant who keeps track of obligations or a spouse who maintains the organization of a household, a diagnosis can be missed. Most patients seeking treatment for ADHD have a legitimate need for care. However, we must be aware that there are patients who are attempting to obtain stimulants for non-medical purposes. One group in particular that is higher risk are college students. Students may obtain stimulants from friends, family members, buying them illegally, or feigning symptoms to a healthcare provider. If you aren't afraid of raising your blood pressure, just Google how to get your doctor to prescribe Adderall. There are websites that describe in detail what to say to fake having ADHD. So why are they doing this? Well, performance enhancement is one of the top reasons, but ironically, misuse of stimulants is negatively associated with academic performance. Other reasons given include to get high, control weight, or curiosity. To mitigate this risk, we need to educate patients and their parents about the legal and health risks of diversion and recognize patients who are at higher risk for diversion. Prescribing medications such as orosmethylphenidate or lisdexamfetamine, which have lower likability for getting high, can help reduce risk. Be aware of the red flags that a patient may be attempting to obtain stimulants for non-medical purposes. These include the patient is unable to describe functional impairments of ADHD, or they report textbook perfect symptoms without any detail or specific examples, or they give inconsistent answers or do not disclose a substance use history. They make specific drug requests or dose or insist on immediate release only. Finally, if they refuse to provide collateral information or past medical records without a sound justification. Other red flags to be aware of are unusual activity on your state's prescription drug registry, failing to give a UA or it's unexpectedly positive, or they misuse the stimulant you've prescribed, request early refills, or report it lost or stolen frequently. It's important that we as clinicians are aware of these red flags and risks for diversion. We must also be aware of our own biases that can impact our ability to accurately diagnose and treat adults presenting with ADHD symptoms. As we've discussed, untreated ADHD in adults is a burden that impacts our patients emotionally, financially, and interpersonally. There's also a societal cost, but because you're here, that tells me you care about your patients and want to expand your knowledge so you can give the best treatment possible. Now Dr. Jane will present about the treatment of adult ADHD.
Thank you, Danelle. And now I'll take over and talk about treatment. So we'll focus on treatment. It is really nice to be with all of you to talk about this incredibly important topic. So it is very important to keep in mind several issues, and throughout my presentation, I'll sprinkle it with key learning points. Here are two. All patients with ADHD deserve proper diagnosis, psychoeducation, and treatment. Danelle made a wonderfully strong point about it. I want to add one more significant issue to our thinking, that it is the young adult, particularly the one transitioning in life from school to college or from college to work, who's very susceptible to ADHD-related impairments. You want to know how susceptible they are? Check this out. This is a very impressive study of individuals who shifted from childhood to young adulthood to adulthood. And I'll have several key points for you to note. By the way, first look at the dotted blue line. Do you see, while some people do lose ADHD symptomatically, not everybody does, in fact, half don't. But I really want you to notice about classic remitting, which is the dotted black line. Majority of people are not there. They are suffering. Not only are they suffering, check this out. The transition years are particularly damaging and dangerous to them in lots of ways. certainly car accidents, certainly unintended pregnancies, and most certainly academic and occupational challenges. So we'll worry about all of our patients, but it's the individual who's transitioning through these major milestones in life that is really challenged. Well, you know what? This is not just true for America. This is British data that shows exactly the same thing, that ADHD does like to be present even in adulthood in a rather large number of people. About 50% of people who had ADHD in childhood persist into adult years. And the second deep learning point is the following. Overlapping and distinctive features of ADHD and common psychiatric comorbidities can be very confusing in the young adult patient. So what do? We certainly listen to the advice Danelle gave us, and I'm just reinforcing those points. Remember, comorbidities are common. There are gender differences. Longer duration of symptom coverage is necessary in everybody, but in the adult individual who has ADHD, it may be of particular importance. Look what I'm calling this slide, double trouble. I think it's correct, actually. It's not just hyperbole when individuals have these comorbidities that I've outlined for you. There are overlapping, but there are also distinct features of ADHD, along with MDD, GAD, bipolar disorder, substance use disorder. But please remember, careful clinical assessment is very necessary. And what do we treat? And the answer is yes, we treat all that we encounter that is causing impairment for our patients. Let me go back to the college age individual. And by the way, when I was growing up, college age was limited. Everybody went to college at 18, you came out. Maybe if you got a graduate degree, you were done by 25, 26. I now have friends who are in their early and mid 40s who are back in college. I certainly have patients who are 18 years old and are in college. So college age years now means pretty extended years, but for the most part, I'm referring to, say, 18 to 25. Here's a study that shows how common comorbidities are in such patients, and it's primarily the quartet of depressive disorders, anxiety disorders, learning difficulties, and obviously substance use difficulties. And many people actually have more than one. Danelle talked about it. Let me also add my strong voice of support to what she said about gender differences. There are gender differences. Females, in some ways, perhaps have less impulsivity, less hyperactivity. Not all, but many times. They often escape attention for longer periods of time. In addition, rates of depression and anxiety are higher. So watch out for ADHD in all your adult patients, but please be particularly cautious about the female patient who's presenting with repeat episodes of depression, repeat episodes of anxiety, or low self-esteem, or even substance use. But let's go with this. Even though there is a referral bias and identification bias, both respond well to treatment. We will talk more about that in just a second. I love this particular way of looking at ADHD. Look at the clock, please. It's not 24 hours. It's not 12 hours. It's actually 24 hours. And I'm going to lay out for you in just a second how much comes at an adult individual in a 24-hour time. Just watch this. And I know what you're saying. It's going too fast. That's exactly my point. It's exactly my point. It goes too fast. If you and I are having trouble just reading these things and these events in a typical adult day, imagine having ADHD on top of that, perhaps even a kid or two, perhaps even college, perhaps financial worries. Just imagine how complicated their lives can be. Therefore, coverage of symptoms for more than just 8 to 10 hours is necessary. And these, dear colleagues, are the top 5 unmet needs, common needs of our adult patients with ADHD when they're receiving treatment. They need symptom coverage in the evenings. They do need to avoid rebound symptoms. They want the intervention to be quite potent. Too slow an onset is not acceptable. And of course, it can't have negative impact on sleep. I'm struggling right now with a female patient who's 21, trying to find just the right dose, duration, formulation. And it's a good struggle. I'm going to keep struggling because all 5 of these needs in her must be met. She's only 21. She's a senior in college. If we do things right, we could potentially change the trajectory of her life in a positive direction. Shall we talk about treatment now? And look where I'm starting out. I think at the right place, which is non-pharmacologic treatments. And here's the great news. Even though the foundational treatment of ADHD, even in adult patients, is medications, non-pharmacological treatment options are a necessity. It is not optional. We should perhaps create that rule for ourselves, all the way from psychoeducation, behavioral interventions, social interventions, even psychotherapy. I will show you how effective that is, even exercise. And most certainly, educational, vocational accommodations, all are necessary. CBT. Now, you might say CBT works for anxiety and depressive disorders, and you would be right. What I wanted to say is 2 things. What if the patient has a combination of ADHD with depression and anxiety? Certainly CBT makes sense, but even for the core symptoms, while it doesn't have great effect size, it can really make a difference, particularly if the CBT follows what's called a coaching model, a skills development model. Mindful meditation. What? I thought we needed to teach them how to focus, not to not focus. Aha, that's our bias. Mindful meditation actually strengthens not just the affective, the mood control, anxiety control. Would you take a look at the last 4 items here? Look at them. Those are actually objective measures. In this particular study, conducted in Brazil, adult patients with ADHD and control patients went through 8 weeks of mindfulness training. Are you looking at how much in terms of objective improvements did occur in attention, impulsivity, and other distractibility factors? So these are noteworthy points. If your patient is open to mindfulness practice, don't not guide them. It is really important to encourage them and to say, yeah, that does make sense. Let's find the right way to go about doing it. Everybody says exercise is good for you, and I buy that. But is it good for ADHD? I do, and I want you to buy it. Here's a very recent study that absolutely makes that point. In this particular study, these are individuals with ADHD laid in a scanner and asked to do a task. So it's not just asking people, are you paying attention better, but actually watching their brains. And then they were asked to exercise. 1 single time, 30 minutes of exercise. Then they were laid back in the scanner and they were asked to concentrate again. Guess what? It improved significantly. Exercise really helped with concentration. But you know what's interesting? Their brain changed. I should rephrase it. Their brain functionality changed even with 30 minutes of moderate intensity exercise. Can you believe that? Can you believe that? That exercise not only subjectively improves some symptoms of ADHD, there's biological evidence for how that happens. Yes, we do need to talk about exercise. But there's no denying pharmacological treatment options are our number 1 way to truly attack the symptoms, but we should always combine it with non-pharmacological intervention. So please remember this. There are many treatments for ADHD in terms of medication. Do we need so many? Yes. Why? Why? Well, the most obvious answer is that's what I've seen in clinical practice. But let me support that by saying the following. There's so many genes involved, different genes involved in the psychopathology of ADHD, it's illogical to assume that one particular medication would attack everyone's symptoms, okay? So we do need multiple mechanisms of action medications. And just to make that point completely clear, let's appreciate that genes, cell functioning, morphology, brain structure, and the disease presentation are extremely heterogeneous in ADHD. If you have seen and met one patient with ADHD, you have seen one patient with ADHD. It's as unique a presentation as the fingerprints on my and your hand. Therefore, having multiple treatment options is a necessity for the clinician. Check this out. It is one of the most genetic conditions in all of DSM's 270 plus diagnoses. It's that genetic. It's not single gene. It's not even 2 genes. It's not even 20 genes. So many different genes are involved. And there are different permutations and combinations of this in individual patients. And by the way, what if your mother was a smoker? Then you know what's interesting? The genes you have may be turned on if your mother was a smoker, but not if she wasn't, as an example. Do you see how gene and environment interaction, even before an individual is born, really impacts the presentation of ADHD? And I do want to remind you, dopamine, norepinephrine, and serotonin. Yep, the triple big hitters are all involved in ADHD. Let's not make the mistake of for 1 second thinking it's all dopamine or all norepinephrine or all serotonin. It's not. The evidence is all 3 are involved, and genetic studies are proving it. Treatment studies are proving the same point. Okay, so what are my options then? What are my options? This is a 2016 data set. It's already slightly outdated, which is great, by the way, which means there have been more treatment options. And there are actually 3 non-pharmacological treatment options that are very close to being approved by the FDA for the treatment of ADHD. We will talk about that some other time. Let's talk about what we have here and now today. Do you see what we have? We have 2 main classes of stimulants. We'll talk about that in just a second. And then we have a whole class called non-stimulants. Which one is best for individual patients? Based on what I've just shared with you, that's an illogical question, right? It is what the patient needs. But what's the data? Shall we talk about atomoxetine for a second? Atomoxetine in adult patients. I was very lucky to be part of these studies 14 some years ago, 12 some years ago. And here's what I'm pleased to show you. In randomized, multi-center, double-blind, placebo-controlled, 26-week studies, atomoxetine is effective in reducing not just symptoms during daytime, but here evening time too. Like all medications, there are side effects. I've listed them for you, and it does require an educated clinician, a cautious clinician, a very methodical clinician to find ways to help patients with atomoxetine. Here's a stimulant. This is methylphenidate, but given in an Oros formulation. You're familiar with the Oros formulation. That's been out for, I'd say, about 15, 20 years. Does it work in adult ADHD? Well, using the AIS-RS scale, it is undeniable that methylphenidate, this particular formulation, actually does work in double-blind, placebo-controlled studies. The evidence is in, and the most common side effects I have listed here for you. There's another form of methylphenidate, but just the D enantiomer in an extended release. That is also available for adult ADHD. May I encourage you to look at the different doses and the fact that it actually does work. It does work quite well. We have looked at it, looking at it both in terms of total score, inattention score, hyperactivity, impulsivity score. These are broad spectrum treatments. What have we seen so far? We have seen a non-stimulant approved by the FDA, 2 more, stimulants approved by the FDA that are in the methylphenidate class that show clear effectiveness. Okay, but what about amphetamines? And I'm pleased to report to you, overall, the evidence base is very strong for the amphetamine class of medications in the treatment of adult ADHD. Look at that. This is the Cochrane database. I chose for you the absolute, what I consider the premier database where biases are removed. And the deep learning point is quite simple. Amphetamines have a high level of evidence for effectiveness in ADHD. Side effects do need to be managed, and there are ways to manage it that we will talk about. Duration of coverage must be adequate. But may I encourage you to look at the effect size? Oh my goodness, very high. Amphetamines are efficacious medications also. So there have been attempts to make the amphetamines become more tolerable and have longer duration of coverage. This is one of them. I was also very fortunate to be part of this. In fact, we were part of the very first trial ever conducted looking at lisdexamfetamine in people with ADHD. And I'm very pleased to show you the results. But what is a prodrug? A prodrug is an inactive drug that the body has to do something to it to make it active. That's a lot of drama, is it not? Well, there's a reason for this drama. By doing this drama, this act of giving a prodrug that the body has to break down, in this case, lisdexamfetamine becomes dextroamphetamine, is the reason for the, well, prolonged absorption curve, better tolerability, and no doubt longer duration of coverage or symptoms. And that's what I'm articulating here. It's also been shown that these are potentially less likable, so they reduce abuse potential, at least theoretically. Okay? All right, so let's move on and let's look at the effectiveness. Did it actually cover the symptoms like we talked about? And you can perhaps see lisdexamfetamine, this prodrug amphetamine medication. Yes, we're not just going to look at symptom coverage, we're going to look at symptom coverage and performance in a modified workplace setting. And you know what? Look at that. Scores from 2 to 14 hours post-dose. What do you see? Oh, there's undeniable evidence for its effectiveness. For the sake of being completely fair balanced, I've put the most common treatment emergent adverse events right here on the slide for your review. Then there is another formulation of amphetamine class of medications for adult AD, and this one is a triple bead formulation. Triple bead. Again, you might be saying, that's a lot of drama. What's the point of this? It is the following. Each bead releases at a different time point in the human gut. As a result, the desire was to not have a sharp peak and a sharp fall. Instead, the desire was to create a more even and a longer pharmacokinetic profile, which the hope was it would lead to longer symptom coverage. And did it? The answer is yes. Here's another study that I was very fortunate to be a principal investigator in. And just look at it. Living with ADHD, general well-being, performance in daily functioning, relationships, bothersomeness about the ADHD symptoms, daily interference, all improved. And again, the most common side effects are listed here for your review. Remember, Danelle and I both said, hey, there's a real issue with patients with comorbidities. So maybe you're asking yourself, can I attack these comorbid symptoms of ADHD by giving them ADHD medications? Well, inquiring minds want to know. What's the answer? Here's the answer. I think you will like my answer. Both atomoxetine and stimulants are actually valid treatment options in patients who have both ADHD and comorbid substance use disorder. That is so amazing. And this one is actually cocaine. So instead of actually worsening one or the other or both, the opposite happened. These people who actually had known challenges with cocaine and known challenges with ADHD, when they were treated for their adult ADHD, actually improved in both. Hold on, do I have more evidence? I sure do. Here's methylphenidate in adult ADHD, even in the face of comorbid substance use disorder. Do you see the deep learning point? Methylphenidate can be used, with caution of course, in these comorbid patients who have ADHD plus SUD. In fact, check this out. 2/3 of the responders actually normalized in their response. So let's not do what perhaps we did 20 years ago, which is deny these patients treatment. Go get your substance abuse fixed and then come back to me. Well, if they could do that, they probably wouldn't be here. In appropriate patients, treating both at the same time is perfectly appropriate. And this has been one of the biggest sticking points, right? Oh, I'm going to make my anxiety disordered patients worse with stimulants. Not so. Not in the average patient. There are 3 key learning points. Number one, about 1/4 of patients have ADHD and anxiety disorders. Number two, they are actually more impaired. But here's the third point. No, they respond just fine. They don't have higher dropout rates. You may have to lower the dose a bit to start with. You may have to add CBT. But no, there was no difference seen in patients who had comorbid anxiety disorders and ADHD in how they responded to stimulants or if they had higher dropout rates. What about primary care? Yes, there's a big role for primary care. You, primary care colleagues, are competent. Danelle has given you a lot of tools, and hopefully I have too. You are more than competent at identifying and treating the vast majority of patients. If you occasionally have patients who do require specialist help, maybe they're highly comorbid, maybe they've failed 2 or 3 drugs, maybe there's a substance use disorder coexisting that makes you a bit nervous. Okay, fine, please refer to us. But the majority of patients, you got it. I have nothing but confidence in you, dear colleagues. You're a wonderful specialty. So in conclusion, in the last minute or so, I do want to tell you that we can follow a paradigm of practical tips. Let's suspect it in your adult patients. If they present with sleep problems, suspect it. Anxiety, suspect it. If they present with depressive symptoms, suspect it. If they present with low self-esteem, suspect it. If they present and say, I'm struggling, suspect it. Screen. Danelle's given us so many wonderful tools. Good job, Danelle. And then finally, always offer them psychoeducation, non-pharmacological treatments, and of course, pharmacological treatments are actually very effective. So you and I want the gold medal for our patients every single time. Here's our Olympic gold medal. This is what we should help them with: attention, hyperactivity, impulsivity, behavior, emotion, all of it. The adult transitioning patient is in real need of our help.
ADHD has been a constant problem for me since I was a kid, really. Now that I'm 22 and have a diagnosis, I worked with my doctor to come up with a treatment plan. I really only knew about ADHD from TV shows and movies, so I was surprised to find out there were other ways to treat my ADHD without medication. So my doctor set me up with a cognitive behavioral therapist, and oh my God, she has been a lifesaver. I really learned a lot from her, and I'm working on my wellness, that stuff that influencers are always talking about. Well, turns out having a regular sleep and exercise schedule actually do help. So my doctor talked to me about medications and helped me find the right one for me. After talking about my symptoms, my lifestyle, and how much I drink, my doctor prescribed me a medication that really helped put me on track for my life.
All right, with that, thank you very much for listening to me. And I and Danelle very much look forward to your questions. Thank you.